Yeah, everything sounds good. I just don't see the slides at all.
We'll share those in a second.
We'll share that hopefully in just a second.
Yeah, the sound is great.
All right. So some of you folks may not know Dilawar. Came here from Michigan, right? How long ago?
A year and a half, 2 years now, actually, this October.
2 years on our faculty, um, and has been a breath of fresh air in trying to revolutionize Montlake allergy, which is quite a task. But he's really done a very good job of making the place more efficient within the confines or constrict, whatever word I'm looking for, the difficulties of working over there. So anyway, he's going to give us an update this morning on anaphylaxis, and we'll get his slides up.
Good morning, everyone. Thanks for coming via Zoom and in person for this presentation on anaphylaxis. The thing that prompted this is that over the last 3 years, we've had two practice parameter updates to our guidelines that are published by the American Academy of Asthma, Allergy, and Immunology. They have a joint task force that addresses these things. And so there are a number of changes that have come in these two guidelines. The first one was released in 2020, and I think with COVID and everything else going on, a lot of people are probably not aware. And the new one is coming this year in 2023. It should be published in a month or two. The draft is available for comment and view online. And it is something that there are sessions planned in the college meeting this November and also in the academy meeting in February. And so I wanted to touch on some of the things that are in those practice parameters because I think they're clinically very relevant and do a good job summarizing kind of the last 10 years, looking at how we manage anaphylaxis and where we may go from here. So my conflict of interest disclosure, that's only one. I hope to add more to this one day. I've served on advisory board for Blueprint Medicines related to systemic mastocytosis. So our learning objectives today, we're going to review the
Hey,
diagnosis
Dilawar,
and management.
we can't see
Yes,
the slide. No slides up.
no slides are up. Okay. Okay, how about now? Is that better?
We see your presenter view.
Okay. How about now?
Still just the presenter view.
Oh, interesting. It says Zoom quit unexpectedly.
It's the same thing I had last week. Yeah, I mean, we can live with that as long as you see the slides. Yeah, see what last week she just presented one presentation. It was, can you see the slides? That's what really counts.
Yeah, we can't see the slides right now.
You don't see the slides at all.
No.
So yeah, you don't really want to understand. I give you the code here. So just go back to the Zoom right there.
Mm-hmm. Interesting.
We might just have to Zoom, just click on
Can you guys see the slides now?
Yes.
It's it's presenter view, but we can see them. You can just, I think it's reasonable just to advance.
Okay, all right. So these are the learning objectives. We're going to review diagnosis and management, key areas in the new practice parameter update that are different from how we've managed things in the past, and then talk about some upcoming advances in treatment of anaphylaxis. So our next slide here, why should we worry about anaphylaxis? Both prevalence as well as frequency of hospitalization is increasing. 0.26% sounds small, but this is for global hospitalizations. So a lot of people get hospitalized every year, and 0.26% of that is estimated to be due to anaphylaxis. Fortunately, mortality has largely remained stable, with a few exceptions. On the bottom here, these two images are from a wonderful paper on global trends in anaphylaxis, looking at data from the US, UK, South Korea, Australia, so a number of different countries. And you can see that the number of hospitalizations are increasing in most countries. Mortality has actually decreased in the number of countries, with the exception of Australia here. A lot of dangerous things go on in Australia. But if you look at hospitalizations, patients that are hospitalized, their mortality actually has decreased as well. So when patients do make it to their healthcare system, they're managing anaphylaxis better and are having better outcomes. So our next slide here is pathophysiology of anaphylaxis. On the right there with neutrophils, monocytes, and macrophages, that is seen in mouse models of anaphylaxis. On the left is what we have in humans. So many of you are familiar with IgE-mediated anaphylaxis, where you have an exposure, sensitization, and then a subsequent exposure. IgE is present, ready to bind the potential allergen, and then trigger mast cell degranulation. This leads to a number of different mediators that are immediately released and then produced. So histamine is the big one that causes a lot of the symptoms of anaphylaxis, but leukotrienes, prostaglandins, heparin, they also play a role. And then basophils, we don't talk about that much, but they are an important cell, particularly when it comes to basophil activation testing, and also the fact that they're in circulating blood. And so in some of these systemic reactions where you have a whole body response to an allergen, they're thought to contribute because they too have the capability of binding IgE and releasing histamine. And so it's thought that they do contribute to anaphylaxis in humans.
I was wondering why mast cells have heparin. And wonder if there's anything in the mucus box.
Yeah, it's a great question. So it goes back to why do we have mast cells in the first place? They exist to contain noxious stimuli. So for example, if you're bitten or stung by something, you want to break down that poison and immediately alert the host, in this case, the human, that, hey, something's going on here. You need to remove yourself from this situation. And so my thought would be is that heparin probably helps play a role in containing poison and breaking down foreign proteins. And if you look at patients admitted to the ICU with severe anaphylaxis, some of them do have bleeding complications. And so while we don't talk about heparin, it can play a role clinically and may have a role in protecting us when the mast cell is releasing a number of mediators to contain, poison that we don't want to spread in the rest of the body. So anaphylaxis can be both IgE mediated and not IgE mediated. So over the past decade, there's been a lot of good work from a lot of different labs looking at other ways in which you can activate mast cells. This is going to be important for how we think about and manage anaphylaxis. The classic pathways on the left, and that's what most of us are familiar with. But complement has been shown to play an increasing role. In some cases, IgG can activate mast cells. And then also the MGRPX2 receptor, which we'll talk more about in this presentation later on, has also become a receptor of interest because a number of drugs are capable of binding that receptor and then clinically leading to the symptoms or syndrome of anaphylaxis. So this is a summary of all the different organ systems that can commonly be affected by anaphylaxis. So most of us are familiar with respiratory and cutaneous symptoms. So you have urticaria and angioedema, so bread and butter for us in allergy. But you can also get rhinorrhea, sneezing, stridor, cough, wheeze, dyspnea. Leukotrienes, histamine play a big role in these organ systems. And then the cardiovascular effects are some things that we really worry about, particularly in patients with severe anaphylaxis. Again, systemic release of histamine and also platelet activating factor can play a role in permeability, vascular permeability, which can be increased in anaphylaxis, leading to fluid extravasation and hypotension in some patients. And the GI system is an area of controversy in terms of how we integrate that in our diagnosis of anaphylaxis, but definitely you can have abdominal pain, vomiting, and diarrhea as part of this system. Not shown here, but something that has become increasingly important over the past few years is that uterine contractions have been described as a symptom of anaphylaxis that is frequently missed. And anaphylaxis can occur in pregnancy, which is another area that we are trying to get more data on, but anaphylaxis, because of its sporadic and unpredictable nature, is something that can be quite difficult to study. So I show this slide not because the fellows need to memorize each of these definitions, but because there are a lot of different ways in which we can define anaphylaxis. It can be as broad as an allergic reaction that has the potential to be life-threatening, to a reaction that involves a specific set of criteria in terms of how many organ systems or symptoms you manifest. We think of anaphylaxis and allergy as, you see it and you know it because you get experience seeing patients. But it's actually quite difficult to define, and there is no universal definition that is accepted by everybody. These are some of the major societies over the past decade: the World Allergy Organization, the European Asthma and Allergy Society, as well as, the American Academy and American College of Asthma, Allergy, and Immunology. Each of these groups have kind of proposed their own definition. And one area that we need more consensus on is a universal definition, because that can make it quite confusing for us in the field when we're taking care of patients, trying to determine when should we give epinephrine and does this patient have anaphylaxis or not.
You can still follow up this one, so the audience can hear if you see it. Or you can hit the select so button that you did at the bottom.
I think that's what causes Zoom to crash before.
Oh, well, don't worry about that.
Not sure you can decrease the size of the note section. Yeah, exactly.
So, one of the things that you folks are probably familiar with is the NIAID-FEN criteria for anaphylaxis. This is one that I do think those of us who see patients and our fellows should know. This is where that two-organ system concept comes from. Back in 2005, 2006, a group of experts got together and defined these criteria. And essentially, anaphylaxis is highly likely if one of the three criteria they described are met. The first one is acute onset of illness with involvement of skin or mucosal tissue, plus at least one of the following: respiratory compromise or reduced blood pressure or signs of end organ dysfunction. The second criteria is two or more following the rapid exposure to a likely allergen. And so what is this? Involvement of skin or mucosal tissue. Again, you see respiratory compromise, reduced blood pressure, so cardiovascular symptoms, and then persistent gastrointestinal symptoms. And so this one includes the GI symptoms, and you don't want to miss potentially anaphylaxis where there's absence of, say, respiratory symptoms or absence of skin symptoms, because if you have, wheezing along with abdominal pain and vomiting, and then that would meet the definition of anaphylaxis under the second criteria, but not the first. And so you do want to make sure that you're not missing potential anaphylaxis. But this concept of two organ systems and looking for that, which is something a lot of patients, physicians, and action plans discuss, is important. And this is something that I think is clinically useful and provides kind of an operational definition for when you may want to consider administering epinephrine or diagnosing anaphylaxis.
Lateral use, the second definition there sort of is one of the specific IgE mechanism by using the word allergy.
Mm-hmm.
We used to use the term anaphylaxis when we thought it was clinically distinct acid, but it was not IgE mediated.
Yeah, I'm glad you brought that up. That term has fallen out of favor, and the reason for that is it gives the impression to some folks that it's not as severe. And so anaphylactoid is an anaphylactic-like, and people are like, oh, okay, this is like anaphylaxis, but maybe not as severe. And that's why the field has gone towards IgE-mediated mast cell activation and non-IgE-mediated mast cell activation, and gone more to diagnosing anaphylaxis as a clinical syndrome, rather than trying to solely rely on an IgE-mediated mechanism to describe it. And while I did show you some pathophysiology early on, you can see that none of the definitions on the previous slide or on this slide make a reference specifically to IgE. And then the NIAID FAN criteria does have this third definition here. So hypotension after exposure to a known allergen. Anyone that's worked in a hospital or admitted patients know there are a lot of things that cause low blood pressure. And so the key here is after exposure to a known allergen. In our line of work, I think we see this most commonly in two settings. One is drug allergy, because those drugs are given IV and infused often, and the other is insect stings, because there are a subset of patients where they get stung and they just pass out. And so their primary symptom is hypotension. And so you don't want to miss those patients. Here, they also make a distinction about infants and children versus adults. And the key here is a 30% decrease from baseline. That applies to both groups. But then a systolic blood pressure less than 90 is also a criteria for adults. So in 2020, the World Allergy Organization wanted to take this criteria, the NIAID FAN criteria, and simplify it for use. I like this picture a lot because it makes it easy to understand. So they took those three criteria and basically shortened it to two criteria. And so they say anaphylaxis is highly likely when any one of the following two criteria is fulfilled. So the first one's going to look familiar to you. So you have acute onset of illness, involvement of skin or mucosal tissue, or both, plus one of these other symptoms. So severe gastrointestinal, which is different from persistent. So some people argue about, what do we classify as severe or persistent? Reduced blood pressure, and airway or breathing respiratory compromise. And then this second criteria is what's a little bit different here: acute onset of hypotension, bronchospasm, or laryngeal involvement after exposure to a known or highly probable allergen. And the reason they wanted to make this change is that, and many of us do this clinically, if we have somebody in our clinic and we're doing a challenge and they tell us the throat is closing off, what do? Administer epinephrine. But by the NIAID FAN criteria, that would not meet the diagnosis of anaphylaxis. And so they wanted to provide more guidance for, when epinephrine should be used. But they did put that caveat in there that it should be after exposure to a known or highly probable allergen. Because anyone, again, that's taken care of patients that have a lot of laryngeal symptoms knows that things like vocal cord dysfunction, anxiety, a lot of other things can affect the airway. And so you don't want to inappropriately administer epinephrine. But they try to simplify this criteria to be used clinically to help providers know when to give epi as well as patients. So when we look at these criteria and look at data related to using them for diagnosis, this is all based on retrospective data. Skin symptoms occur in greater than 80% of cases, which is why both of those first two criteria in the NIAID FAN criteria and in the WA revised criteria include mucosal or skin involvement. And then absence of skin symptoms does not exclude the diagnosis, which is why you have the two organ systems. And then in the third criteria for the NIAID FAN criteria, also the mention of hypotension after known allergen exposure. GI symptoms are a lot more challenging. A lot of folks have chronic gastrointestinal symptoms, can be IBS and other conditions, for example. And so the key here is persistence and severity after exposure to a known allergen. And this is where, you're going to see some difference in how providers practice. Our food allergy action plan that we use here at UW says to administer epinephrine for vomiting after food allergy exposure. Whereas in clinic, when I'm conducting a challenge, if a patient has one episode of vomiting and vomits up their food allergen, I often do not administer epinephrine. And this is based on, my clinical experience that if they vomit up the allergen, you remove the exposure and many of them get better and you don't need to administer epinephrine. And so, I would say that GI symptoms, especially in isolation, can be challenging, but you always want to consider the exposure to the allergen and their history, and then the persistence and severity of those symptoms. And then, why is the clinical diagnosis important? If we underdiagnose anaphylaxis, you have increased morbidity and mortality. Epinephrine is not appropriately administered. And if you overdiagnose it, that causes harm as well. A lot of folks say, what's the danger to one more EpiPen in the world? But we're starting to have data showing that if you give someone an epinephrine autoinjector inappropriately, potentially, or it's unclear if they really need it, it does not lead to improvement in quality of life and may actually lead to a slight reduction in quality of life. And so I've kind of shifted away from just casually handing out epinephrine autoinjector to anyone that it wants and really thinking, does this patient need it? And yes, that takes more time and there's a role for shared clinical decision making. But I do think that we need to be more thoughtful with our prescription of epinephrine to patients. So anaphylaxis is a wide differential diagnosis. This is also covered in the new practice parameter update. So things you want to think about are neurologic and autonomic dysregulation, because that can affect the cardiovascular system, You want to think about other forms of shock, PE, which can, acutely manifest as hypotension and respiratory compromise. Endocrine conditions, because those frequently cause flushing, increased heart rate, things that can be mistaken for an allergic reaction. We do this to patients with the drugs that we give them, vancomycin, niacin, anesthetics. Niacin's interesting because there are a number of wellness products now that are being given to patients, supplements of various kind, things like athletic greens, for example, many things, energy drinks that contain B vitamins. And my colleague and I, Dr. Sun, have seen a few cases now where patients present with concern for allergic reaction to these products, and it's often the niacin that is the cause, and flushing and anxiety and palpitations gets mistaken for an allergic reaction.
One of the residents presenting nice.
And then, we can have toxic effects. So scombroid is something we always talk about. I've diagnosed one case in my career, not here, a different place. But essentially the key here is, it's spoiled fish and multiple people have the symptoms. And it's the histamine not being broken down properly in the spoiled fish and the bacteria metabolizing it that results in just a ton of histamine ingestion, which can then cause symptoms that look like anaphylaxis because histamine release is an important part of that.
Yeah, I've never understood that. I just think when you eat this, you break it down in your gut, you don't absorb it systemically. Am I wrong about that?
So, gut permeability is an area of increasing interest. It used to be that, we would tell people that they didn't have intestinal hyperpermeability, but now that's been increasingly described by a number of labs and groups. And this is a big thing with the microbiome and how we understand food allergy exposure and how things are transported across the gut. I would say more and more we're learning pore barriers, whether that's skin or gut, play a role in the development of allergies. And I think that every patient's gut is probably unique, and that you can get a lot more things crossing the barrier than we previously thought. And, in our differential diagnosis for anaphylaxis, another thing that, has come up that we've learned from the COVID-19 vaccination campaign is immune stress-related response. And essentially, this is a general stress response or a vasovagal reaction, potentially including syncope. And so, COVID vaccinations have taught us that, just relying on subjective symptoms can overdiagnose a lot of patients with allergic reactions and anaphylaxis. And I've boxed here what I think are some helpful things when you're approaching a patient clinically. So in a general stress response, you often have an increased heart rate or normal or increased blood pressure, whereas anaphylaxis, you would potentially expect hypotension with compensatory tachycardia. And then in a vasovagal reaction, you often have a decreased heart rate with a low blood pressure, which, if someone's on a beta blocker or other blood pressure medicines, you still could potentially see an anaphylaxis. But in general, you would expect a compensatory tachycardic response in anaphylaxis. And so sometimes what their vitals do can be helpful if you have that documentation. And then you have often a lot of subjective symptoms in these situations: lightheaded, dizzy, feeling numb or weak, tingling. So these subjective symptoms you should always consider, especially in relation to COVID-19 vaccination. Is this a vasovagal reaction or a stress response? And sometimes some of these associated findings and looking at the vitals, if you're lucky enough to have those in the record, can be helpful in kind of distinguishing, is this truly anaphylaxis or not? So next thing I want to talk about is severity. So there's the increasing movement, and this is again mentioned in the new practice parameters, to categorize allergic reactions, in particular anaphylaxis, as mild, moderate, or severe. And this is a pocket card that was developed. So I envision a future one day where fellows carry this around in their fleece or white coat. And if they see a patient with a reaction, of course, they provide the appropriate care, but then use this card to think about, is this mild, moderate, or severe? And, risk stratification is going to be really important going forward. But I think the big takeaway from this is that folks that have hypotension and hypoxemia or severe anaphylaxis or severe allergic reaction, where those folks that have symptoms that might be correlated with these things could potentially be mild or moderate reactors. And we'll get into why this is important later on when I go into management and some of the new updates to how we manage anaphylaxis. But I did want to put this on folks' radar that we want to do a better job of classifying severity. In addition to this, we have subtypes of anaphylaxis. So there's been an effort to describe these things. So when we talk about anaphylaxis and study it, there's a consensus of what we're talking about. So persistent anaphylaxis has now been defined as highly likely when the following criterion is fulfilled. So you have symptoms and or exam findings that fulfill anaphylaxis criteria that persist for at least 4 hours. So this 4-hour time frame has now been proposed as defining persistent anaphylaxis. Refractory anaphylaxis has been defined as presence of anaphylaxis following epinephrine administration and appropriate medical management. For example, given IV fluids, to potentially ensure that the epinephrine has something to press. And then initial reaction has been treated with 3 or more appropriate doses of epinephrine. So somebody that's required a lot of epi for treatment. And so this is now what's been proposed as refractory anaphylaxis. And then biphasic anaphylaxis, which can make anaphylaxis difficult to manage clinically, has been defined when these 4 criteria have been fulfilled. So new or recurrent symptoms or exam findings that fulfill anaphylaxis criteria, initial symptoms and exam findings completely resolved before onset of these new symptoms and exam findings, absence of allergen or trigger re-exposure, so that's important, and then new or recurrent symptoms of examination findings occur within 1 to 48 hours from complete resolution of initial exam findings. And so, there are rare case reports of biphasic anaphylaxis occurring at 48 hours or past that. And we'll get into more on, the data behind biphasic anaphylaxis, but essentially you have complete resolution of your symptoms with initial treatment, and then a recurrence in the absence of a repeat exposure to the allergen or trigger within a 48-hour window. And that's now what has been proposed as the definition of biphasic anaphylaxis. Yes, we will discuss that as well later on. And so I wanted to talk about the course of anaphylaxis because folks will read about biphasic anaphylaxis and providers will often be concerned about it. And the more data we've collected on this, the more we've realized that most patients do not have anaphylaxis that is persistent, refractory, or biphasic. And really the 2 things I bolded there are the biggest things for determining your risk of biphasic anaphylaxis. The initial anaphylaxis is severe, hence why, it's important to classify it, as mild, moderate, or severe, meaning they have hypoxemia or hypotension or significant end organ dysfunction. Some studies have documented a wide pulse pressure, which would correlate with early arterial dilation, again, playing into that severity and hypotension. If the anaphylaxis trigger is unknown, often these are patients with recurrent idiopathic anaphylaxis or a mast cell disorder. A few studies have actually linked the presence of cutaneous signs and symptoms as correlating with having biphasic anaphylaxis. And then drug trigger in children, one study identified, drug reactions in children as being more associated with biphasic anaphylaxis. We do have one study now, retrospective, that shows 1-hour symptom-free observation following initial resolution of anaphylaxis is associated with a 95% negative predictive value for biphasic anaphylaxis. And we see this in our clinic all the time. We have a patient that fails a challenge, we treat them with epi, we watch them for an hour and send them home. And so 1 hour of observation, assuming they respond to treatment and their symptoms have completely resolved, essentially has a 95% negative predictive value for biphasic anaphylaxis. So you can tell patients, now that you've gotten better, there's a very high chance you're not going to have biphasic anaphylaxis. So what about patients with recurrent anaphylaxis? We always talk about that any reaction can be life-threatening and potentially worse in the future. This causes a lot of challenges for management and significantly contributes to patient anxiety. The chart on the right there is from a paper that looked at patients with idiopathic, recurrent anaphylaxis, mast cell disorders, hereditary alpha-tryptophasemia, people that had more than 1 episode of anaphylaxis. And in this study, they had them fill out questionnaires about their onset of symptoms. They looked at severity when you go through and review the chart and try to categorize the severity of the reaction. And it was included 164 patients, and they calculated kappa values to see, if someone has a reaction, how similar are their future reactions to their previous reaction. I always tell patients, and this is with the caveat, the best predictor of future behavior is prior behavior. And so that is true, at least partially, in anaphylaxis. And what they found is only 16 of the 164 patients had reactions of varying severity. And so it seems that in patients with recurrent anaphylaxis, that future episodes are comparable to prior episodes. And it's not true that you're going to have more and more severe actions if you keep getting exposed or keep having reactions in the future. There are caveats to this, and we'll get into that in a second. because there are a lot of things that go into determining the severity of a reaction. But I see parents come into my clinic all the time for food allergy that have been told by their primary care or their ER doctor or family friend that, you know, the first exposure, you get sensitized, the second exposure, you have a mild reaction, the third exposure, you're going to have severe anaphylaxis, the fourth exposure, you might die. That is not true. And so I would say that how we counsel patients is important, and that we have more and more data suggesting that there is some level of consistency in an individual patient for their future allergic reactions.
I think that's the emergency room docs, it's universal that they tell patients the next thing is going to be worse.
Mhm. Absolutely. I think we unnecessarily scare patients to make them take this seriously. And I think it's one of the cases the pendulum swung too far the other way, and now we need to get back towards the middle. Because we do want people to take this seriously. It's the potential to be life-threatening, but we don't need to scare them to death. So a number of factors affect severity. I like this infographic because it highlights a lot of the different things that might play a role. So the dose of allergen can play a role. We most commonly see this in food allergy, and also actually in immunotherapy. So if you look at some of the most severe reactions to allergen immunotherapy, it's when there's a dosing error and they get way more allergen than they should. So the dose of allergen can play a role. The allergic disease burden, so someone would say uncontrolled asthma or lots of comorbidities, that can affect severity, and then how we manage the patient. Did we timely administer epinephrine? Were there cofactors like NSAIDs or aspirin? And then also, was there heat or exercise or alcohol? And so there are a number of things that can make what would have been a mild reaction become a more severe. So when I tell patients that that's not a guarantee that your future reactions are going to be more severe, I also discuss all the things that possibly could make it more severe. So they're aware of these cofactors, and I think that's appropriate counseling. And so I think if you counsel patients appropriately, you're more likely to see that future reactions will be comparable to prior reactions. So I'm going to shift gears a little bit and talk about using tryptase to diagnose anaphylaxis. Many of us are familiar with the 20% plus 2 rule. That's what I learned in fellowship. That's what's been validated in perioperative anaphylaxis, and what a lot of people use when they're trying to determine if someone had a tryptase drawn with an event, is that a clinically significant change? Our colleagues at the NIH have challenged that. And the reason they challenged that is in their cohort, which includes many patients with idiopathic anaphylaxis, recurrent anaphylaxis, mast cell disorders, hereditary alpha-tryptasemia, they found that if you just take the same patient with an elevated tryptase and recheck it when they're asymptomatic, many times they'll fulfill that 20% plus 2 rule with no correlation in symptoms. And so they tried to create a new rule based off of all of this data and mathematic modeling. And what they found is that if you're 1.6 times your baseline tryptase, that seems to have a better sensitivity and specificity for determining a clinically significant change in your tryptase, of course, in correlation with the history and symptoms. And so our new practice parameter update doesn't recommend using a specific rule per se, but does discuss when you have 2 tryptases, one of them presumably with symptoms and the other at baseline, that you should consider using more than one equation to determine if that's a clinically significant change. And that if you're checking serial tryptases, say yearly or every 6 months, if it's somebody with an elevated tryptase or a mast cell disorder, that a 20% plus 2 rule does not necessarily indicate that they're having anaphylaxis, which I think to a lot of us are obvious, the patients sitting in front of us in clinic. But when you have these rules and criteria, sometimes they get blindly applied. And I did box the link here. Anyone in this audience can go to this link, put in their patient's data, and get a calculation.
Is the new rules specified to the general population or only mass?
Great question. So this has not been validated in a population outside of the NIH's cohort. And that's one of the limitations of using this equation. I would say that if it was me, I'd probably calculate both. The 20% plus 2 is pretty easy math. And then, this is like going on MD-Calc. You just punch in the numbers and see what you get and compare the two. So this is the diagnostic evaluation for anaphylaxis that has been proposed in the new practice parameter. Like everything in medicine, it starts with a detailed history. And then you think about, was there a trigger that precipitated the event? And so then you can consider skin testing or serum testing based on the trigger. And if those things are available, you can also consider, measuring a tryptase level, which is why I went through that calculation on the previous slide. And then based on the tryptase elevation, you can consider further workup. And it is important to get a baseline tryptase, because sometimes what will happen is you'll get a tryptase with an event and it looks normal, less than 11.4, the lab calls it normal, and then you get a baseline, you find the patient's baseline's lower. So they're on the lower end of that reference range, and then you have to calculate, was this a significant change? So normal tryptase does not exclude anaphylaxis, and if you get a tryptase with an event and don't have a prior for comparison, make sure to repeat the tryptase, because it can look normal on first glance, but may be a clinically significant change for that individual patient. And then here, the parameter does mention to consider alpha-gal. This is something that I talk about a lot because I did part of my training at the University of Virginia. We don't have a lot of alpha-gal out here on the West Coast. We don't got that Lone Star tick to bite patients, but patients travel, ticks are migrating, they follow deer. And so there is now a specific reference to this in the new parameter saying if you live in a geographic area with the Lone Star tick or you have a history of tick bites, and there's a concern for anaphylaxis, you should consider checking alpha-gal IgE. And so with alpha-gal, it's a syndrome of delayed allergic reactions to the carbohydrate galactose alpha-1,3-galactose, or alpha-gal for short. Sensitization is thought to occur through tick bites. Amyloma americanum, or the Lone Star tick, which is pictured on the right. The Watts spot tick is what some patients call it. It's typically found on deer, so hunters, people that live near forests, people that go out hiking a lot in geographic regions, they have the opportunity to be exposed and bit. They found alpha-gal in the saliva of these ticks, and also sometimes in the GI tract of ticks as well. On the bottom right here, these are both images from the CDC. It's the geographic distribution of the Lone Star tick. This is changing. They're moving north and to the west, and the thought of part of that is global warming, part of that is deer migration. There have been reports of sighting Lone Star ticks in Canada and in Michigan. This is something that potentially will impact more and more people based on, a lot of geographic factors. And these patients can present with anything from urticaria angioedema to severe anaphylaxis. The kicker here is it's 2 to 6 hours after eating the meat products. And that goes back to intestinal absorption, which Len asked about a question earlier. The thought is the alpha-gal has to be bound to lipids and transported across the GI tract. And then that lipid alpha-gal complex is what can then bind IgE systemically and result in a systemic allergic reaction. This also brings up other important concepts in food allergy. We have the food matrix concept where depending on the protein you're allergic to, sometimes that's contained in a matrix of other things, and you need some digestion and breakdown before the immune system is capable of recognizing that epitope and triggering an immune response. This is also the only food allergy that I'm aware of that's diagnosed based on a ratio. And so anytime you get an alpha-gal IgE, you need to get a total IgE. And the reason for this is that we have good data from both in the US and outside the US that a ratio of 2% or greater in comparison to the total IgE has a 95% positive predictive value for having clinical symptoms on exposure to mammalian meat.
So it's more than just having a positive alpha-gal IgE.
That's correct. The reason we know this is if you take people in endemic areas where the Lone Star tick is present and just randomly test them for an alpha-gal, up to 30% of patients can have a positive alpha-gal IgE and be totally asymptomatic. So as we all know, sensitization does not imply clinical allergy. It is important to always think about the history. But this ratio is helpful because if they have a very low level detected and no symptoms, it's likely just sensitization without clinical allergy. So anaphylaxis in infants and toddlers, I did want to address this. It is mentioned in the new parameter as well. These are direct recommendations from the new parameter. We suggest clinicians be aware that in infants and toddlers, patient age is not correlated with reaction severity. A lot of times we think of, children potentially having more severe symptoms and needing to be more conservative and have a higher threshold of protection. And I get that, we want to be protective of kids. But just because you're young doesn't mean you're going to have more severe anaphylaxis. And we have a lot of good data from early introduction of food allergens in other countries like Australia and Korea, for example, where they recommend just blanket introduction for everybody for a lot of foods and not necessarily trying to determine a risk. In the US, we take kind of a more in the middle of the road approach where, if you have bad eczema or egg allergy, for example, it's recommended you be screened for peanut allergy based on NIAID guidelines. But in countries where they're just introducing foods to high risk and low risk to reduce the likelihood of developing IgE-mediated food allergies, they're finding that a minority of infants and toddlers are developing severe anaphylaxis. And that goes to the second point. We suggest clinicians be aware that anaphylaxis is unlikely to be the initial reaction to a food or medication upon first exposure. And so, they do emphasize we need more data in this area, but what we have so far suggests that, we don't need to worry that just by nature of being an infant or toddler that you're going to have more severe reactions. So presentation of anaphylaxis in infant and toddlers is also important. Obviously, infants cannot describe symptoms, and you may miss some potential signs of anaphylaxis because, there's natural behavior that infants might do. Children do what they want, right? And so sometimes it can look like they're having a bad time, but they're totally fine. But some potential cues you might look for: ear picking, tongue rubbing, putting hand in mouth, neck scratching, change in general demeanor. I've frequently seen in my clinic, and anyone that's taking care of children with food allergy, that a kid's behavior will totally change right before they anaphylax. They'll become very quiet, not responsive. The parents will notice the difference, and then the vomiting and the hives and the wheezing, all that comes after. So these are things to keep your eye on, but can also be part of just normal infant behavior. And the new parameter still recommends using the NIAID-FAN criteria or the WHO anaphylaxis criteria to assist with diagnosis because we don't have anything else. So even though this hasn't been validated in this population, the two organ system thing that I showed you guys earlier, that's still the same set of criteria that we should use. So diagnosis of anaphylaxis and epinephrine. This is something I've been guilty of doing in the past. And the fellows will tell you, I'll often ask them when they staff a patient with me, if they told me somebody got epi for a reaction, I asked them, how did the patient respond? Did the patient say the epi made them feel better? We're actually now trying to move away from asking this. And so these two recommendations are from the new parameter. We suggest that meeting diagnostic criteria for anaphylaxis is not required prior to the use of epinephrine, and that neither the clinical decision to administer epinephrine nor the clinical response to epinephrine be used as a surrogate marker to establish a diagnosis. And if you think about this, it makes sense, because if someone has, say, diffuse hives to something and you administer them epi, you're trying to prevent progression to a more severe reaction. It's not that, hives alone should be considered anaphylaxis in that context. People can have side effects from epinephrine. It may save their life, but they also may feel more anxious and jittery. I've seen people have tremor and vomiting after being administered epinephrine. And so it does make sense if you think about it. If someone's got epi and then felt terrible after, it could be due to the side effects. It may still save their life. And so we want to get away from saying if you got epi, if someone gave you epi, that was anaphylaxis. We want to make sure that we administer epi when we think it benefits the patient, even if they don't meet the diagnostic criteria for anaphylaxis. And so, I am now trying to change my practice and not rely on using administration of epinephrine as a potential surrogate marker for the diagnosis. So let's talk about epinephrine. It's a non-selective adrenergic agonist that is the first-line treatment for anaphylaxis. 0.01 mg per kg of 1 to 1,000, 1 milligram per ml solution. In Europe, 0.5 milligrams is the adult dose for the epinephrine injectors. In the United States, 0.3. That's also for older children. 25 kilogram cutoff to move from 0.15 dose. This is important. A lot of times providers see a kid in front of them, even if it's an older, bigger kid, and they'll still prescribe the 0.15. And so you do need to keep eye on the weight, and that's why it's important, especially in pediatric allergy, to make sure you have an up-to-date weight. And then there is a 0.1 milligram auto injector on the market made by our friends at ABQ. This is the 7.5 to 15 kilogram range, but the new parameter does emphasize that it's still okay to prescribe the 0.15, because you should consider things like cost and insurance coverage for patients. And so I do think it's very important to make sure you're giving them something they can actually afford and use. No medication, how great, is beneficial if the patient can get it or use it. And so I do think that if you have access to the 0.1, it's great to prescribe for the younger children. But if you don't have access, 0.15 is fine as well. Some folks are concerned about younger infants, 4 months, 6 months old, prescribing them a 0.15 auto injector. But in an emergency situation, I'd rather give a little bit too much epi than no epi at all. I like this picture on the right here, which is from a study published in 2001. They took some healthy male volunteers and administered them intramuscular epinephrine, and then measured, the serum levels of the epinephrine. And what they found is if you give it in the deltoid or you give it subcutaneously, the levels are lower. And that's why it needs to be in the muscle of the thigh. The caveat to this is that we don't know the minimum serum concentration of epinephrine needed to treat anaphylaxis. And so it's possible giving it in the deltoid or sub-Q gives you enough epi to treat a reaction, but it would be unethical to conduct that kind of trial. And so, I would say that based on pharmacologic data, it really should be an intramuscular injection that is administered in the anterolateral thigh. That is correct, yes. So the thought is that you can give a single dose rather than have to carry 2 epinephrine auto injectors. And so I think part of it is convenience in having the full dose administered in a single injector. The other concern is as our populations get heavier, in Western countries, is 0.3 going to be enough? But again, that's hard to determine because of the fact that we don't know the minimum serum concentration needed to treat a reaction. But I think it was approved as 0.5 for a variety of reasons, and that's what folks have stuck to there. And in the US, they want 0.3. Why our regulatory bodies have not approved a 0.5 dose here, I don't know. Maybe that's because those companies just haven't sought to make that change because, it is more drug, so potentially more expense, right? If you can get away with the lower dosage, I imagine that's cheaper to produce. So there could be a variety of social, financial, pharmacologic factors.
Make a different product.
Yes, they have different injector brands that have different dosages. That's correct.
Dilawar?
Yes.
Yeah, this is Frank out in the cloud again. I'm just curious if you've heard any updates on the nasal epinephrine.
That'll be in the section where I talk about future therapies for
Okay.
anaphylaxis. So I will be happy to address that in a little bit. So factors. Thanks. Factors to consider for epinephrine auto-injectors. So here we have a variety of things that are important, I think, when you counsel patients and talk to them about the safety and how to store and use the injectors. So needle length may impact efficacy. On the previous slide, I showed you sub-Q epinephrine injection leads to less of a serum level, so it could potentially impact efficacy. Needle length also can affect injury. You don't want to give an IO injection, right? And so you want to make sure that you consider needle length and the size of the patient. Sometimes you're limited by what products are available on the market, but it is something to talk about that some of these adverse events that have been reported with epinephrine, could be potentially related to the needle length. Stability is very important. A lot of people worry that an expired EpiPen is completely useless. That's false. We have studies now showing that 1 to 2 years after expiration, there's 92 to 98% stability. 3 to 4 years after expiration, there's 87 to 92% stability. In the past, the FDA has even allowed folks to continue to have expired EpiPens for up to 4 months past expiration date when there were shortages for epinephrine auto-injectors. So I still tell folks an expired EpiPen is better than no EpiPen. Of course, the preference is always to have an up-to-date prescription. Extreme heat can reduce activity. So the biggest thing I see is people leave it in the car in the summertime, and that's not great. You have the potential to reduce the activity. Some people have actually looked at does freezing or thawing alter the activity, and the answer seems to be no. And then, of course, insurance cost is a consideration. And so you always want to prescribe something the patient can actually afford and have covered. Should you always prescribe an epinephrine auto-injector? This is a question that people are increasingly asking. And so, what are the benefits of always having an epinephrine auto-injector? You can shut down reactions quickly, whether they're mild, moderate, or severe. It can simplify management if you just give epi for everything. And it's easy to train patients if all you're using is an epinephrine auto-injector for everything. It's one thing to review as opposed to talk about multiple scenarios or multiple products to use. What are the downsides? So it is an invasive medication, intramuscular injection, at least for now. It has negative patient perception. And the reason for that is there's a lot of anxiety, particularly in children with food allergy about, injecting my kid with a needle. Skin symptoms and isolation are almost always minor and self-limiting. So you don't necessarily need to give epi for that. You can treat it with antihistamines. It can actually result in reluctance. Again, going back to the needle, the concern for side effects, historically always sending all patients to the ER, which we'll talk about. There can be a lot of issues related to the perception of using epi, the potential safety of epi, and then a lot of hesitance to use that even when it's indicated for more severe reactions. And so, we're moving more towards shared clinical decision-making and really being thoughtful about, when we should prescribe epi versus not. I will go as fast as I can. So we recommend routinely prescribing epi for patients at higher risk of anaphylaxis. When deciding whether to prescribe to lower risk patients, you want to use shared decision making. So this is a slide looking at risk factors associated with severe or fatal outcomes. So folks that are older, have cardiovascular comorbidity, certain types of anaphylaxis. So these are things you'd want to think about, patients potentially of higher risk. In these situations, you would want to prescribe epinephrine. If these things are absent, you might want to consider a discussion. On this slide here, they talk about lower likelihood versus higher likelihood. This is in the practice parameter. So for example, in pollen food allergy syndrome, if there's no history of systemic reaction, many of us don't prescribe EpiPen for those patients, where if there is a history of symptoms beyond the oral pharynx, many of us will treat that like a traditional food allergy and prescribe Epi. With venom allergy, if it's a large local or even a cutaneous only systemic reaction, you don't actually have to prescribe epinephrine because their risk of conversion is pretty low. Whereas if they have more severe reactions, you would want to prescribe Epi. With latex allergy, if there's an occupational exposure, you might want to consider, versus, if they're very good about it and they don't work in occupation where they're going to be exposed, you may not need to carry Epi. Drug allergy, we don't typically prescribe Epi, but if there's a concern for occupational exposure, you might. And then there's some cases where you want to give it, like, exercise-induced anaphylaxis. In all cases, you should prescribe Epi. With physical urticarias, cold-induced urticarial people can go swimming, and if they jump in a cold pool or lake, that can cause anaphylaxis. And so in these patients, you'd want to consider prescribing epinephrine based on what they do. And so these are all considerations. So EMS activation after Epi usage, 80% of anaphylaxis will resolve spontaneously with minimal symptoms. How many times does the patient come to your office and say, I had anaphylaxis and I gave my kid Benadryl and they were fine? There's some truth to this. You want to be aware of that and discuss that with patients. Only 10% of reactions, this is all based on retrospective data, have a suboptimal response to the first dose of Epi. 2 to 3% will require 2 or more doses of Epi, and there's little evidence that sending them to the ED changes anything. What do they do in the ER? Not give Epi, give steroids and antihistamines, watch them for a couple hours and send them home. This is a at-home management algorithm for anaphylaxis that was published with the COVID pandemic. This is something that I have given patients in the past, and now I've moved to a model where I discuss with patients whether or not they should go to the ER after giving Epi. Generally, if it's no risk factors like on a beta blocker or, mast cell disorder, they resolve after the first dose. There's somebody there to watch them and help them. I'll say Epi yourself, watch yourself at home, make sure you have somebody nearby, a way to call 911. But if you're feeling good, you don't need to go to the ER. Half of the patients think I'm crazy and still go to the ER. The other half say, that's great, I'm more likely to use Epi. Not that you all need to switch to this model, but the thing I want to emphasize here is you should have this discussion with patients about potentially moving to this model. And this is recommended in the new practice parameter. They do say that you may not require EMS activation, and they do try to provide some guidance on scenarios where you consider that based on risk stratifying patients as having more likely to have severe anaphylaxis or less. And so this is, I think, where we're going. A lot of people are not going to, I think, make the shift yet because what are doctors worried about? Getting sued. I think there's, liability concerns in consideration, but when you look at the data and what benefits our patients, I think at least discussing this and giving patients the option would be a way to go. This is the 2020 practice parameter update. I just want to highlight 2 things here. Antihistamines and glucocorticoids are not reliable interventions to prevent biphasic anaphylaxis, but may be considered as a secondary treatment. There is no data that putting somebody on steroids will reduce their risk of biphasic anaphylaxis. Stop giving steroids for anaphylaxis. And then here, evidence is lacking to support the routine use of antihistamines or glucocorticoid pre-medication in patients receiving low or isoosmolar contrast material. We still do this at UW. Most hospital systems still do this. Antihistamines and steroids do not prevent anaphylaxis to radiocontrast media. There have been reports of patients dying because they had a contrast reaction. They got contrast again. Nobody sent them to an allergist, and the providers thought that giving antihistamines and steroids would prevent it. We had a case here where a patient was pre-medded and then had severe anaphylaxis complicated by Kunis syndrome. This is a case that one of our fellows will be presenting in an upcoming national meeting. But if it's radio contrast allergy, you really should skin test them, see if there are alternative agents you can give them. Don't rely on medication to prevent reactions. So beta blockers and ACE inhibitors, the widely held assumption that if you're on this, it's contraindicated to do anything that would potentially cause anaphylaxis. The actual evidence to support this assertion is very weak, and there's a lot of conflicting evidence on the actual risk. Few studies have been able to tease out, is it the medication or because you have cardiovascular disease and you're on that medication that causes the risk? And a lot of the early reports that identified this as a risk factor for severe fatal anaphylaxis didn't distinguish between selective versus non-selective beta blockers. A lot of people are on these meds for a variety of reasons. They save lives when it comes to heart attack and diabetes and stroke. And so we don't want patients to, not be on these medications because of all their benefits. And in general, most cases, the risk of stopping these meds is greater than the risk of severe anaphylaxis if the medication is continued. Really emphasize the role for shared decision-making. Because we're short on time, basically the venom immunotherapy, you should still do it if they have a severe reaction history, regardless if they're on a beta blocker or ACE inhibitor. When it comes to other things, like food and drug challenges, desensitization, if they can hold it for the procedure, great, you should do that. If they can't, you should still probably do the procedure, but you can have that risk-benefit discussion. And then with aeroallergen immunotherapy, because generally environmental allergies are not life-threatening, there's a more measured approach here. It's preferable to be off these things or switch them if you can. And this applies to both initiation and maintenance, but neither of these medications is an absolute contraindication to aeroallergen immunotherapy. I get patients that come in all the time and say, I was on shots at a private practice and my doctor said that because I'm on beta blocker now, I can never do shots again. I think it's more a role for discussing the risks and benefits here and doing shared decision making. You can't have an anaphylaxis talk without mast cell disorders. So there is a score now that has been recommended by the new parameter, the REMA score. So if you have a patient come in with a history of anaphylaxis, you can calculate the score. If it's greater than 2, there's a high likelihood of clonal mast cell disease. You probably should get a bone marrow biopsy and work that out further. If it's less than 2, you can continue to monitor them and consider other causes. But this is validated and is one of the recommended scoring systems in the new practice parameter. Hereditary alpha-tryptophanemia. The big thing here is if your tryptase is greater than 8, you could have HAT. And so when you're working up an elevated tryptase, this is something you should consider ordering. Affects 4 to 6% of the Caucasian population. Very controversial whether or not it causes disease or symptoms. The jury's still out on that. We have conflicting evidence, but just remember tryptase greater than 8, you should consider testing for this diagnosis. All right, so new therapies for anaphylaxis. This goes back to mast cell biology. A lot of you will be familiar with some of the drugs on here. So you can either target the inhibitory receptors on mast cells. So you can bind things like Siglec-8, so you send an inhibitory signal so they don't activate. You can block IgE or block the signaling triggered by IgE. So omalizumab, which is FDA approved for chronic urticaria, and now ligelizumab, which has shown good data for chronic urticaria, and these things are also being explored in food allergy and other atopic conditions. So if you know the mechanism is IgE, you can target the IgE, but then you can also go one step further and give them things to target the cellular signaling triggered by this binding. So you block them at a lower level. So Bruton tyrosine kinase inhibitors have actually shown some benefit in patients with food allergy in terms of reducing severity of reactions, or in some cases preventing reactions completely. KIT inhibitors, so you have the inhibitors that can block D816V, the mutation in most patients with systemic mastocytosis. Avapritinib was just FDA approved for indolent systemic mastocytosis. It has been previously approved for aggressive disease. Midostaurin and imatinib have been used in more aggressive disease and overlapping conditions with, hypereosinophilic syndrome, for example, with imatinib. And so if you target other things that affect mast cell proliferation, differentiation, and survival, you have other ways to intervene. So we're trying to move beyond epi, and as we under mast cell biology more and more, you can target drugs that go after these different pathways. The MGRPX2 receptor, so there's actually an inhibitor being developed for this. Vancomycin, opioid, MASP-related protein receptor, and so it has much longer name, but I think it's way easier to say MRGPRX2. But vancomycin, opioids, fluoroquinolones, these things all bind these receptors and cause mast cell activation. This is why the first time you give somebody ciprofloxacin, they can have anaphylaxis and you don't need sensitization. So it's important to understand the mechanism, but you can also intervene on this. So they're trying to develop inhibitors for this receptor. And there could be a world 5-10 years down the road where every patient gets this before they're given vancomycin, or they're given an opioid, or they're given a fluoroquinolone, especially IV in the hospital. And you could prevent a lot of the non-IgE mediated anaphylaxis or reactions that you see. And then alternatives to intramuscular epinephrine. There's 0 trials demonstrating the benefit of an epinephrine autoinjector in treating anaphylaxis, but that's the standard. And so how do you design a trial to evaluate new ways to deliver it? You look at serum levels and peak levels. So Cmax and Tmax, that's your surrogate. You look at the pharmacokinetics and pharmacodynamics. People have looked at intranasal, sublingual, and inhaled epinephrine. And this is some of the data. So up here, you have the sublingual epinephrine, here you have inhalational, and here intranasal. The problem with this is that, patients can absorb these differently. So you need to study them in a wider population. And then what we don't have, and one of the reasons that folks think the intranasal epinephrine application was rejected, is if you need repeated doses, how well do they absorb that? A lot of these are a single dose and then comparing it to a single dose of epinephrine, but we don't know if someone needs more than one epi injection. Do you then tell someone on one of these nasal, sublingual, or inhaled products, okay, carry an EpiPen as well, and then inject yourself with epi if you need a second dose, or do you say take more of your sublingual or more of your inhaled or more of your intranasal? And that's one of the reasons the FDA cited for wanting more data on the intranasal epinephrine is we don't know if you need a second dose, what that looks like, and if you achieve, comparable and appropriate levels. So while we do have data to suggest, these are comparable, at least in a single dose, because some patients may need a second dose or more epi, we need a little more information on how repeated dosing does. And I think if we get that, we will hopefully see an approval for one of these products in the near future. Not for anaphylaxis. That's true, but it goes to the number of puffs. And it's estimated that to achieve comparable levels to intramuscular epinephrine, you might need anywhere from 30 to 35 puffs. And so how practical is that? How well do the patients tolerate it? So you might need something that's more concentrated and can do it in fewer number of puffs for practicality. So one of the limitations was the amount of puffs that they had to give kids to get a comparable level to 0.15 milligrams of epi. All right, I know I'm a little over time, so the word of the day is treatment. This is a QR code for any feedback. What can I do better in the future? What did I do well? My employers appreciate folks commenting on my talks. So please provide any feedback. Thanks for listening. I'll take any questions anyone might have. Another day, yeah. It looks like we do have some in the chat. Which lab is commercially providing tests for HAT? So Gene by Gene, which Dr. Chow. So the the Zoom chat here. There's a question about commercial testing for hereditary alpha tryptophanemia. The company that was first to do it, that I have used in the past, because I think they have a good system, is Gene by Gene. They're located in Texas. They can send kits to your office. There are other companies that now have commercial HAT testing available. They're often at the Quad AI and college meetings advertising their products. I don't have personal experience with those companies yet, but hopefully as more people enter the market, the prices will go down. It's about $170 last time I checked for HAT testing. It's not covered by insurance, so patients have to be prepared to pay for that testing if they want to be tested, but many patients do want to know what's causing their elevated tryptase. You can often get the results by logging into your account with these companies or having them email or fax the results and then putting it in the patient's chart and going it over with them. I think Dr. Bont had asked about the intranasal epi is the second dosing data that we're missing on that.